I see a lot of white coats. Remembering my days of yes. So where we start? Stroke. The most burning topic of today's discussion, as always, is stroke. As we all know, stroke is a brain attack, and time is brain. So the whole idea of managing stroke is how fast we can act and how fast we can treat the patient. So this is how the stroke works in anterior circulation. If you have the complete middle cerebral artery blocked, you will have this white shadow on MRI. This is MCA superior division, MCA inferior division, anterior cerebral artery, and ICA means internal carotid artery watershed. Posterior circulation, lateral medullary, medial medullary syndrome, and ICA because the occipital cortex is there. What is the pathophysiology of stroke? You have to understand this. Once the artery is blocked, this area, which has a volume of less than 10 ml per 100 gram per minute, is complete infarction, that is irreversible. But we are concerned with this area, penumbra. The velocity, the CBF is between 10 to 20. So we have to save this area. The whole effort of managing stroke is to save this penumbra. And the other area is, the rest area is with the CBF is more than 20 ml. You have collaterals in some patients, you don't have collaterals in certain patients, so you have to assess them before you start the treatment. Stroke imaging, the basic tool of stroke imaging is CT scan, brain plane. Why CT brain is important? Because you want to rule out hemorrhage. So you can start IV thrombolysis if patient is in window period of 4 to 4.5 hours. Beyond 4.5 hours, patient is for mechanical thrombectomy. They are extending window from 4.5 to 6 hours. Trials are going on, but still we feel that 4.5 is a decent for IV thrombolysis. More than 4.5 hours, you must go for mechanical thrombectomy. But before going for mechanical thrombectomy, you must assess the vasculature. Is it really worth doing a mechanical thrombectomy for this patient? What will be the outcome? How are the collaterals? Which artery is involved? Which territory is involved? So everything has to be understood by the imaging. So whole idea of imaging is how fast we can do the imaging. Some say 10 minutes, 15 minutes. Some takes more time because technician doesn't know the stroke protocol sometimes. This is how, as I told, middle cerebral infarction, you see on MR. Superior branch, inferior division, more of parietal infarcts. Total occlusion, superior and inferior. You see the whole white area on diffusion-weighted images. Lenticulostriate basal ganglia infarctions. Anterior cerebral artery. You see this area here. Lacunar infarcts are the smaller infarcts because of the penetrating arteries. So you can have lacunar infarcts in the watershed area. This you most see in MR, small white hits are there always. These are the 4 P's of stroke imaging. First is the brain parenchyma. You assess early sign of acute stroke, rule out hemorrhage as I earlier told. Second are the pipes. Pipes means you have to understand the vasculature. Extracranial and intracranial circulation. Perfusion. This is now a new tool because the window has been increased from 6 hours to 24 hours. So if you have perfusion after 6 hours in your system, you can fairly treat more number of patients. Then you have to assist cut through the thymus and one supraclavionic cut. And then we divide this area into 10. We give the score of 10. So 10 means is you have M1 is anterior cortex, M2 cortex lateral to insular ribbon, M3 is posterior MCA carotid, M4, M5, M6. Then you have caudate, putamen, internal capsule as well as insular cortex. So if they say the number is less than 7, the prognosis is bad. CT early signs. Hyperottenuating brain tissue. You see this very early sign on CT. If you see a mild differentiation of grey and white matter on CT, you can fairly pick up an infarct. But if you see a complete hypodensity on CT at 6 hours or maybe 3 hours, that means the infarct has set in. Second is obfuscation of the lentiform nucleus. You see this area. It will be obscured in early signs of stroke. Then is insular ribbon sign. You see near the insula, you see this hyperdensity, the ribbon. These are depictors of stroke. This is the classical sign. You see a thrombus in the middle cerebral artery. This is the dense MCA sign. This you normally see on a plain CT. You don't need a contrast for this. Then you have to rule out hemorrhage. Then you have all this MRI. MRI is the modality because diffusion picks up stroke at around 45 minutes to 1 hour. And then you mismatch it with ADC and see if you don't have perfusion. But if you have perfusion, it's better to do a MR or a CT perfusion to understand the penumbra. So you don't wait for a window of 4.5 hours. You can do a bridging of IV thrombolysis, then take the patient to cath lab and treat the patient if it's in a large vessel occlusion. Because that saves time of 4.5 hours. You bridge with the 20 milliequivalents. Don't give a full dose. These are the stroke signs. If you see carefully, no vessel white dots are seen on this side, normal side in MR. And you see small MR. Hyperintense vessel signs, you don't see on a plain MR. If you have this cortical, swelling of this cortical area on MRI. Then you have this diffusion MRI, bright on diffusion early stroke, dark on ADC. And if it's dark on diffusion and white on ADC means it's a subacute or a chronic infarct. Then the latest is CT angiography. You see this MCA is occluded. Why CT angio is important? You understand the site of occlusion. You see the collateral circulation and you see tendon region. Tendon region means you have a stenosis distally in MCA and you have a problem in internal carotid artery proximal. So you have to understand that, then only you can plan treatment. Either you have to do if it's a tight stenosis, you might have to do a balloon angioplasty of the carotid, then take your aspiration or Sulambra catheters. Then on the way back, if we can do acute stenting of carotid, if it is urgently required. Otherwise, it's better to wait for 5-7 days or maybe 2 weeks is the ideal time to wait to do a stenting if you can manage at that time. This is how a mural hematoma dissection will look on a fat suppressed T1 weighted MR, like the vessel wall imaging. This whole asterisk is the mural hematoma within the wall. And if it's an acute infarct, you will see enhancement of the carotid. This you see on susceptibility weighted imaging, you see a black thing. This is above the gradient imaging. If you see this black thing and if it is more than 8 mm, this is the thrombus. That means IV thrombolysis might not work if it's a bigger thrombus of 8 millimeter. Then you have this collateral other vessel signs. They develop as a part of brain mechanism to protect the tissue. If it's a large vessel occlusion of MCA, many patients have, they are lucky, many patients doesn't have. So their infarction rate is higher. But once you open the artery, this will go off in subsequent MRs. Now we have ASL imaging, which is non-contrast. We don't have to give contrast. Or gadolinium. We can see through and adjust the area. Now, after imaging, once it is done, we need to understand what can be done for that patient. Either IV or mechanical thrombectomy or combined approach. Earlier, the results were not encouraging because devices were very less, efficacy was very less. Then all these trial happened like MR Clean, Escape, Extend, Revest, Swift Prime. They all started using Solitaire. Solitaire was a laser cut stent meant for clot extraction. It comes in two sizes, 4 millimeter diameter and 6 millimeter diameter. Earlier we were using only 4 millimeter for MCA, but now we prefer a 630 or a longer stent retriever to extract the clot with aspiration also. I personally first go with aspiration. If it fails with 2 attempts, I take the stent retriever. Or if I feel it's at the ICA bifurcation, the ICA terminus, aspiration won't cross. So it's better to use an aspiration proximally in ICA and use a stent retriever to open that area. Then came diffuse trial, and which extended the window from 6 to 16 hours. Then came the latest dawn trial, which extended the window to 24 hours. Earlier we were stopping at 6 hours. Now we can do stroke from 6 hours to 24 hours, but we should have evidence by perfusion. Perfusion, if it shows a viable tissue, penumbra, we have done cases at 23 hours. One case was done as 25 hours. And generally, we have seen this trend in posterior circulation rather than from anterior circulation. These were the old devices. Techniques: stent retriever or proximal balloon guide, stent retriever plus aspirations. Aspiration. This was a new catheter. Earlier we had only 48 catheter. Now we have catheters up to 72. 72 means the bore is big, flexibility has increased, and aspirations, the suction capability has increased to a greater extent. This is how the aspiration catheter looks. You see the bore. But it is very flexible because of these transition zones. Sometimes it just goes over the wire. And this is his aspiration catheter, the pump to aspirate. This is the canister where the clot is collected, and this is the tubing. This is the aspiration technique. Adapt. A direct aspiration first pass technique. What we do here is, we take the aspiration catheter over a micro up to the clot. We try to pump the catheter within the clot, and you see from the back. If there is no flow, that means it has trapped the clot. Then you aspirate both the catheter with the pump, or if you don't have pump, with a 50 cc syringe, and the guiding sheet with a 20 millimeter syringe, and extract the clot with a negative suction. This is a new device, RED 72. Trackability is excellent. This is the posterior circulation. You see this catheter up to here. This is the thrombus. And we suck the clot. Other thing is, you see the trackability here. It is so tortuous, it is moving like this. Then going into the brain. See here. And then we are aspirating. This is the outcome. Now coming to stent retrievers. Because sometimes aspiration fails, we need something which gives us foolproof plan to take out the clot. Some clots are very nasty, they don't come out. Except you try, but there has to be a limit how much aspiration or how much passes you can do, because every time you do a stent retriever pass within an artery, you are injuring the wall of the artery, the median. So you are scrapping it. You are pulling an open stent retriever. Advantage with aspiration is it works, it is very smooth from the outline. So the injury to the artery is less. This is how the stent retriever works. See, this clot has been trapped. This is MCA occlusion. Single pass aspiration, and you get this clot. Now you have Solitaire 2. and solitaire platinum. It has market at almost 10 centimeter area. You see this. You can see the retriever in whole length. So that gives you a vision where you are parking your stent retriever, where you are unsheathing it, and when you are removing it. Normally now we are using a 440 or a 630. We are using a longer retrievers. That gives us more flexibility. This is aspiration retriever technique for stroke. This is Tulumbra. What we do here is, we put the stent retriever, then we push the aspiration catheter, and we take out both with a negative suction. You can remove the microcatheter of the stent retriever, so that gives you more space for aspiration. This is a push and fluff technique. So you see the cell area is less. When you push with the wire, the cell area increases, so your entrapment increases. But you have to be very careful while doing it. You should not dissect the artery by putting a more force. So you have to understand with your hands what is the size of the artery. If you don't respect the vessel is going to give it back to you. And that will be a very nasty, especially because you are working in a closed environment. Then there is no coming back. This is the new technique what we are following now, a safe technique. What we do here is, we take the stent retriever almost 2/3 of the clot ahead. Then we take the aspiration catheter at the proximal end of the clot. So we trap the clot in between stent retriever 1/3 part and aspiration part. And then we make it tight and we aspirate the whole thing. We can still remove the stent retriever catheter so that we get more space. This is how it works. Long sheath, guiding, aspiration, micro wire. So you have this much, this is the assembly. But you have to be really quick. This is the revised care. Means you can use the stent retriever wire like preset, Appeal, Revive, and do the stenting on the way back. You don't have to take another wire. If you really want to do a stenting. This will not work for solitaire. This will work only for preset because they are 1/4 wire. Solitaire wire is smaller. Now, the third part, coming to the cases. This was a 21-year female presented in emergency, left-sided weakness and deviation of the mouth. If you see MR, right MCA is not seen. You have an acute infarct. This is how the aspiration catheter is there. And we remove the clot. This is my diagnostic catheter now. This is the long sheath. Second, 62-year female presented here with sudden onset right-sided weakness. We went ahead. You see this MCA is not seen. We cross the microcatheter through this block, check the distal vessel. So we need to know the extent of thrombus. So we need to see it with distal, give a small whiff of contrast and see. Then bring it back and see the aspiration catheter stuck there. And then we aspirate it. Third case, another 70-year female with sudden onset, slurring of speech, loss of conscience, left side weakness. You see a right elbow just at the bifurcation. See a long sheath with the aspiration catheter. See micro and checking the distal circulation to see the extent of thrombus. Then I have aspirated. See, the bifurcation is there only. The clot was stuck at the bifurcation. Another 71-year female presented with sudden onset left side weakness with slurring, difficulty in walking and deviation. See the right MCA is blocked, anterior temporal artery is filling. You see the spiral vessels. See the aspiration catheter over a micro. And see, but you see carefully, there is an underlying stenosis. So there must be some atherosclerotic intracranial. So you have to be really worried in senior patients, in aged patients, because you can have underlying atherosclerosis. So you have to be very gentle with your microcatheterization. Another case, CA endometrium with metasitis, presenting with slurring. You see now it's a distal M2 block, inferior division block. So we have smaller aspiration catheters for this, a 3 max. We place the catheter and then we open it. I generally wait after opening the vessel for 20-25 minutes because we have seen sometimes it's reoccluding. So you have to wait in cath lab for at least 20 minutes to get fully satisfied that what you have opened is staying open. Another case, you see here a thrombus lying at the proximal ICA. So we aspirated this first with the aspiration catheter. You see the clot has been aspirated. Right M1 is blocked. This is the long sheath. Went with the micro, crossed, and we aspirated. Another 85-year-old patient in ER, inability to talk and stand with right side weakness. Left M1, aspiration tip catheter. And this patient had a distal AC aneurysm. So first we opened the vessel. This was the hypodensity C, distal AC aneurysm. So first we did a mechanical thrombectomy, and then we did coiling of the aneurysm for the same patient in the same sitting. Another case, patient was undergoing coronary angiogram and they were taking left subclavian angio. It was on-table stroke in cath lab. There was infarct in the PCA, acute. See, the left PCA is not seen. From left subclavian angiogram, and see the clot aspirated. Intracranial atherosclerosis. You have this MCA block, and one pass aspiration was done already, and my aspiration catheter I could not negotiate. So I left it here. I put a stent. You see the marking of stents. This is the end of stent. After doing 2 passes, you see here, vessel has opened, but there is underlying atherosclerosis. So now we have to follow it up on later on antiplatelets and do a follow-up at 3 months and 6 months. Sometimes they heal with anti-inflammatories also. Another case, operated for growth in sigmoid colon. ACA, you see MR, bilateral ACA infarcts. Left ACA is occluded here, anterior cerebral artery. Went with the stent, opened this artery, but you see underlying atherosclerosis. So you can't do more passes. If 2-3 passes are done, it's better to stop and accept the fate that it is not opening, rather than injuring the artery more. Another case, left periventricular infarct, CT angio, left M1, just distal to bifurcation. Here we went, we checked the microcatheter distally, where the occlusion is. This was the infarct hyperperfusion, already infarcted area, which you are seeing on the MR. See this hyperperfusion there. Then we went with aspiration, it didn't work, slightly opened. After second pass also it didn't open. The clot was very rigid, it didn't come. Then we used the 440 solitaire. See some narrowing, but it didn't open, it again closed. Now we use the 630 solitaire. 2 passes done, clot was broken. Then we aspirated again and see the clot, yellow, thick clot. This was the final angiogram after a struggle of 2 hours. But you still see there is some narrowing here in the superior. And you see some hemorrhagic transformation. but it was limited. Patient did well. She took time to recover. It was left distal ganglion. This was a CRPF Juan, right MCA. We did 2 passes with the solitaire. See the marking of solitaire distally. And this was open. You still see the lumen of the MCA is not healthy. Another case, basilar artery is not seen. You see a thrombus. This is on SWI, black thing. Right vertebral artery is ending in pica, posterior inferior cerebellar artery. Left vertebral artery is not seen. Somehow we crossed with the wire and gained some flow. Went ahead with the catheter, checked the distal flow. 1 pass done. See the catheter solitaire tip. It didn't work. Then we did a balloon angioplasty at the vertebral ostium. Better opening now. Went ahead. The vertebral V4 segment forming the basilar. Now the PC has opened, but still there was some narrowing. And see the thrombus here. We did another pass. Now it is clear. But now we had to tackle this ostium. So we put 1 stent vertebral, but you see a dissection happened while placing a stent. So put, still the flow was, it was open artery. We put 1 stent, you see a dissection. We went ahead, put another stent, covered this dissection. And this was the end result. Patient did well. She took time because posterior circulation, but she is better now. Tandem occlusion, as I was talking, carotid occlusion as well as ICA occlusion. Did a plasty, opened it, then put a filter so that distal migration of clot should not happen. Placed the acute stenting by putting the patient on tirofiban. Had risk of hemorrhage, but it's okay. This is a rapid software program. By sitting at your home, you can see what the imaging has been done on your mobile phones. So everything is there. You can do an extended window. This was completely thrombosed artery. See the narrowing here. Opened it, stented it. Thank you.
This is Lake Palace from old.
Old.
So water is there all the time, all the year now. So you see, you don't see water. Because now we have that steam round the clock, water is around. Very nice presentation. So basically, I mean, as you were telling that in your basically time window is like based on penumbra, I mean perfusion. So if ever, I mean, if any case is beyond, are you aware of any literature that beyond 6 hours, without doing perfusion imaging, can you do clinical flare mismatch or any other criteria would you use?
We have done 1 or 2 cases. 2 cases I have done, 6 to 24 hours without perfusion. But I was not happy with the outcome. Because I don't have a direct evidence that what I am dealing with. You are doing it because either there is a pressure to do something for this patient-like situation. But if there is no perfusion between 6 to 24 hours, I think it's better to not do because you are doing more harm.
Yeah, but there are some reports, some cases now that, clinical flare mismatch.
Then now you have this ASL imaging on MR.
Yes.
Not many MR centers have this sequence.
Yes.
If you have this ASL sequence, that gives you some idea of penumbra. It's non-contrast.
So I come back to this because you are a trained radiologist and interventionist, right? So perfusion imaging is not a problem for you at all. But when you generalize, like in my state, in Rajasthan, we have, almost 1.52 lakh strokes. Okay, that's incidence of stroke. Out of this, if you combine like 1/3 would be like 40,000, something like that, would need a large vessel occlusion opening. Okay, so 40,000 people need opening per year. And how many we do in the whole state of Rajasthan? I mean, you would be amazed to see. I mean, the Indian data all over the country is like 1,000, 2,000 patients. In Rajasthan, let's say it's 100 only. So half of this would happen in this center only. So what I'm trying to tell you, because if you make peripheral imaging mandatory, it will be more difficult to recruit these patients. We need to have simpler criteria.
I understood your point. Thing is, if you don't have perfusion, take ASL. At least you have some idea. In 6 to 24 hours. If it's less than 6, we just go. We bridge. We might do it 2 hours. If my neurophysician feels I'll bridge it, you go ahead. There are certain patients who do very well if you are acting fast, not waiting for the window. And every patient is different. Guidelines do help, as sir was telling. But in every patient, guideline doesn't work. You have to go by the book, but understanding the patient. The scenario there in front of you, imaging, patient condition, neurophysician, emergencies, clinicians, everything has to be brought into one thought process. Sometimes I tell them, don't give full dose because you are increasing my risk of hemorrhagic complications. Just bridge it because patient can come from ER to cath lab, the 10, 12, 15 minutes, some drug is going on that might help in melting the clot. So it might make my job easier rather than giving a full dose. Then I have to stop in cath lab because I have to give heparin. I don't want a thrombus with my guiding and all.
Yeah, but then now head-to-head trials, whether you need to bridge every patient or not.
It all, as I told, it all depends on the patient right now in front of you. You have to be flexible.
Your approach in these LVO patients, what is your approach?
So I have seen that some of those patients with connector plates get analyzed. But those who don't, then we have to go ahead and do the patient. But by and large, I have seen that if you see that when you are doing the MRI and if you see there is active, better is to go straight for the mechanical treatment rather than waiting. Waiting for 15 minutes, half an hour is okay because by that time you push them into get there. Because the risk, as you said, of the hemorrhage with using that. So I feel that I take a decision depending on that particular time, how is the patient. I feel that if neurological condition, visceral artery, of course, you don't have to, you have to just go in and do the thing.
But sir, one problem I have faced with connective plates, bridging is very difficult. Because it's a single bolus. Actylase you have 20 milliequivalent and 50. Connector come in only one vial. And most centers keep 50 ml instead of 20. I think you...
Yeah, we keep 50.
Yeah. 20 is not there, but 8 is available.
Lastly, what is your take on large core infarcts? Would you open them?
No.
Within first
More
6
than
hours?
70 ml.
No. Sir, same with you?
I think large infarct you can't, but if you see that, like recently last month, I had a patient who came after 12 hours, the patient has, and we got an perfusion and diffusion scan. Though the 12-hour passed out, but I saw that there is a great mismatch. So we went in and...
So he was not a fast progressor.
Yeah.
He had collaterals which hold it down for 12 hours.
Exactly. So I think sometimes the patient may progress slowly. The clot is adding on to that. So like a strategy.
That is their luck at that time.
Yeah. So we said we'll 12 hours. Let's do the diffusion study. We did the diffusion. And same time another patient diffusion study we did. The clot has increased in the size compared to the other. Rakesh said we can't do anything to it. Conservative treatment.
I have said no to few patients, sir, because you have to understand, you are not giving any help to the patient, spending a lot of money and outcome will be remain the same. And some do well if you don't touch at that time. They do well at 3 to 6 months period. Once they settle down with the infarct.
All the report says at 3 months.
Yeah, 3 months they settle down.
But within first 6 hours, if you have a large infarct, now there are trials that you have a large infarct with open vessel. Of course, you have to decompress them. A large infarct, open vessel with a decompressed brain, that's better.
Yes.
So how do you explain this?
Like
That
large
within
infarct
first 6 hours,
on CT or MR?
MR, let's say MR.
Diffusion MR.
Yes,
But
diffusion
you have to
MR.
compare it with flare and ADC.
Yeah, but within first 6 hours, large infarct, that's actually
You
we
see
don't
many
do.
patients are fast progressors. So within 2 hours they show the signs.
Yes, so
Some
size is
don't
large.
show.
Size is already large, more than
Then
1/3.
better to do a decompression or at the earliest.
Yeah, but would you open the vessel before decompression?
No, no. Because you are creating problem for the person who's going to do decompression.
But I mean, there is some literature coming up these days where they have done, they have planned decompression along with opening of the vessel. And they have shown that probably at 1 year or 3 months follow-up, they do better. So there are some studies coming up. I mean, we don't do it, obviously.
But
There is
doing
some,
it,
they say open vessel is a much better thing than having a closed vessel. Even if it's a large infarct, but there are island of preserved brain tissues. So by opening of the vessel, even if you have produced hemorrhagic transformation in the process,
you never know how big it will be.
yeah, that's true. But obviously they have not undergone thrombolysis.
Because it's a large infarct, your hemorrhagic transformation is likely to be more.
Yes, yes.
Then if you do decompression,
But nowadays in
time is
stroke
gone.
conferences, this is a very hot topic, and many people argue that we should open the
Every
vessel.
center has a different philosophy.
Yeah.
They work on a different philosophy which suits their center. And some neurophysician, they
That's
have their own.
very important. That's very important. I think this is the key. What you and your institute are best at. So that's what the precisely
I also feel that the patient and their relative are important.
Yes, sir.
What they want. There are many people who want to spend the, many people say that I don't, that there's a 5% complication, we don't want to
It
accept.
happened yesterday. Left MCA, 80-year-old, 75-year-old. We convinced, told them, but after half an hour they say we don't want.
Exactly. So many times you may want to do it.
But relative doesn't want. So respect everyone who's around for the patient.
Exactly.
which is the biggest barrier for thrombectomy in your setup?
Cost.
Everywhere it is cost. Everywhere it is cost, whether it is Mumbai or Udaipur or any other
Cost,
Jodhpur
straight
also,
away
sir, it is
10
cost,
lakh.
right, sir? Because nowadays we have more and more patients coming up.
Solitaire is 2.5 lakh rupees. Plus
Sir. Amrita, we are doing it in 6, the procedure.
our place is 10 lakh.
6 lakhs procedure.
Cheaper than us.
Cheaper because they have kept some negotiated plus markup. No
I
advance.
hope that this new catheter which is coming,
Nivo.
Philip Yaugal has also endorsed it, that will reduce the cost substantially to 1/3.
Maybe, sir.
Yeah, and I think it should be available
But the
soon.
problem is we have to understand the trackability of that.
They say it is very good.
They say, but in your hand, how it works, we need to understand, sir.
Let's see.
Because I have worked with React 72 penumbra devices. They are more flexible. You put Medtronic React, sometimes it is stiff. You put others.
Again, these are the individual's technique, how good you are, like if I use the bottom toxin, both of I use the both. So whatever you are comfortable with, you would like to use that particular.
Better not to change hardware once you are starting your stroke.
So thank you very much, Dr. Arvind. It's been wonderful talk. Very nice. If there are any questions or comments, please most welcome. The whole idea of mechanical thrombectomy, this is such an underutilized procedure. Unlike cardiac, you do primary angioplasty. I would say the Indian statistics are like 8 lakh people would have stroke every year. Out of them, 1/3 would have large vessel occlusion. And you can imagine the amount of thrombectomy happening in our country is to the tune of 1,500 or 2,000. So that's pity actually. So all these patients with large and vessel occlusion, they invariably land with a handicap, and they are handicapped for lifelong. The message is, because now there is extended window period, 6 hours was conventional window period. Now you have patient up till 24 hours with you. If somebody is having a large vessel occlusion, MC occlusion, basilar, and now with Nivo also, which Arvind has not covered, but medium vessel occlusion, now we have better devices and tools where this medium sized vessel can also be opened. So that makes whole difference in outcome of patient. So time is big. So this is the take home message from Dr. Arvind. Thank you very much, Dr. Arvind. So next from here, we have another colleague from Jodhpur. He has a lot of interest in headache, Dr. Praveen Kumar Suranaji. He has been our senior, and his specialization is in headache, epilepsy and vertigo. And sir, if can request you to come up, and he'll be talking about approach to migraine, approach to headache. And he'll be especially talking about, these trigeminal autonomic cephalgia. And so please feel free, as I said in the beginning, to ask questions, to make comments. If you have any doubts, don't hesitate. So this is a very informal interaction here. It's not a conference setup. You are in a classroom. So please feel free to ask whatever you feel like. So till the laptop is set up, so nowadays my headache, migraine, trigeminal autonomic cephalgia, so now obviously red flag signs has to be, and there's so much to do in primary headaches nowadays, apart from pharmacological therapy, which has always been standard of care. You have other things, biofeedback, and I would even say meditation, yoga, and all those things does make a difference in outcome. So we have to be aware of all these modalities, and over to you, sir.
Good evening, everybody. And that's basically that's a clinician. And I have never been, or I have never held any position as a teacher, but by instinct I am teacher. So I will love to ask question, and I will love to see the resident answering my questions. Okay? So approach to headache will be our topic today. Headache is defined as diffuse pain in various parts of the head, with the pain not confined to the area distribution of a nerve. This definition is very important. When you are dealing with when you come across a patient of headache, very simply, if you are not able to differentiate trigeminal neuralgia from headache, you waste a lot of your time in identifying a different way. So this definition is very clear, that not confined to the area of distribution of nerve. This will differentiate immediately. If you respect this definition, trigeminal neuralgia will not come into your picture, or orofacial pains will not come into your picture, and you will lead simply with the headache. Now, headache will be classified into primary headaches, benign, recurrent, or no organic disease. So, out of this primary headache, the commonest which I come across in my OPD is migraine. Although tension type headache is the commonest one, then comes migraine, and third one is the cluster type. But most of the neurologists see in their OPD the migraine as the commonest headache. So, meaning thereby, I expect all the physicians also to see whenever they come across a patient of headache, every patient of headache is migraine unless put otherwise. So this is first carry home message, that if you have seen a patient of URI and he has basically through the headache and you are going to give him treatment for the URI, ask one question. आपको और भी कभी headache हुआ इससे पहले? इसमें कुछ सालों से headache हो रहा है? If this is the target years of migraine, ask this question very softly. पर सर मुझे कभी सर दर्द होता है, उल्टी भी हो जाती है. Okay, this is patient of migraine. So if you give the URI, but you are not going to deal with the second aspect of his headache. It may be possible that URI has precipitated his migraine and you are just looking into URI part. So this is very important. Unless put otherwise, so carry home message is unless put otherwise, every patient of headache is migraine in your OPD. Even if it is headache, take history. It may be transformed migraine. Take detailed history. Headache usually is not emergency, meaning thereby give due attention and some time to patients of headache. This is very important. What happens that the headache is taken by many people as very simple. I think paracetamol लिख देते हैं, Nestom लिख देते हैं. No, respect the patient of headache. Give some time. And I again repeat, every patient is patient of migraine unless put otherwise in your OPD. If you are neurologist, all the more true. Now, beside the primary headache, you will also have patients of secondary headache, and most of the time I don't see patients of the secondary headache. So, when I see the patient of secondary headache, seen earlier by the physicians, perhaps they were missed because they were busy. because most of our MDs are good, knowledgeable, but they are overburdened with the patients and they are missed. Okay, why they are missed? We will listen later. Now, acute secondary headache disorders. What are the acute secondary headache disorders? Headache associated with the head trauma. I will not deal with that. Headache associated with the vascular disorder like subacute hemorrhage. Everyone knows it, and we will not discuss that because sudden onset. Subacute hemorrhage, sudden onset. At one moment, person is okay. At second moment, he will have severe headache and can get unconscious in a minute's time. So this is subacute hemorrhage. And when you come across this history, just see whether the patient is negligent or not. Look for the, do a detailed examination, but you should be very fast and to best of your ability, you should be very fast. In the patient of subacute time is important. Then comes your acute ischemic cerebrovascular disorder. I think I will not deal with that because we will have this many other things. Ruptured vascular malformation on vascular malformation can lead to acute secondary headache and arthritis. Now, temporal arthritis is important cause of headache. Usually this is in the 5th and 6th decade. Now, classical teaching is that ESR is raised. Few patients may not raise ESR. Classical testing also ascribes jaw claudication, etc. But we come across with patients who have hardly any of these features, just fatigue and headache on the temporal area, or it may not be temporal, just malaise, headache, which is not confined to particular area, not even diffuse, but is not having also character of the migraine. ESR is also not raised. So what is the new thing? In recent case, it has been found that if ESR is not raised, CRP will be raised. Carry home messages, either of the two or one of them will be raised. And if you are suspecting in a susceptible age, a patient of temporal arthritis, immediately start steroid, get imaging and start steroid, don't wait for anything else. We are very steroid sensitive, immediate results will be gained within 24 to 48 hours, so that will be diagnostic. So either ESR will be raised, or CRP will be raised, or both will be raised. So carry home message is in 5th to 6th decade, a new onset headache, or patient never had headache, but headache is not falling into the category of primary headache, and is not in a particular category. If it is in temporal, it's okay. If it is temporal artery is tender, it is okay. But if you are suspecting that it can be temporal arteritis, go for ESR and CRP. Either of the one of the two will be raised. ESR may be normal, CRP may be normal, but both of them will not be normal. So this is the carry home message that in temporal arteritis, typical diagnosis is not difficult, imaging will be normal, and they are very sensitive to steroids. The treatment may, in older patients, may carry on for months together. If that is the position, switch over to azootherapy. Now, headache associated with the non-vascular intracranial disorder like, I think I will listen that. Then comes benign intracranial hypertension. Pseudotumor cerebri. Recently, the name has been called, it is called idiopathic intracranial hypertension. But pseudotumor cerebri is again a separate word. Now, pseudotumor cerebri is seen mostly in the women with obesity. It may be drug induced, it may be steroid induced, it may be metronidazole induced, vitamin A induced. And here the things, the clinching points which differentiate from the migraine with which it may be associated. So I have seen many, in fact 1/3 of my patients of benign intracranial hypertension are patients of migraine. And very recently it has been also been found that those patients of benign intracranial hypertension which are treated successfully subsequently develop migraine. This is very interesting. And there are explanations. It is said that once the benign intracranial hypertension has developed, these patients, those circuitries which lead to migraine is activated, and they develop headache akin to migraine. So when you come across a patient of benign intracranial hypertension, don't get don't forget the message that migraine may be associated thing or subsequently patient may have migraine. Now in benign intracranial hypertension in OPD, there is a very interesting phenomena which is called visual obscuration, transient visual obscuration. The person will describe that I have got reduced headache, मेरे headache पूरे सिर में सर दर्द होता है, it may be throbbing, it may not be throbbing. तो कई वो कहते हैं सर दर्द होता है लेकिन मुझे अचानक रोशनी जाती है और ठीक हो जाता हूँ, थोड़ी देर बाद में मेरी रोशनी बिल्कुल ठीक हो जाती है. This visual obscuration is not seen usually in other conditions. And one of the important things is many of the physicians don't keep ophthalmoscope and don't use. When you are dealing with the patient of headache, you cannot get divorced from ophthalmoscope. Use ophthalmoscope, every patient's fundoscopy should be done, and benign intracranial. Most of the patients are diagnosed by having either fan papilloma, the margin, or they are venous or with possession are absent, or they can also have sickness. So benign intracranial hypertension is not difficult to diagnose, and they have got many interesting imaging features in the MRI. The CT is not that useful, but MRI is very useful and an astute and good radiologist will diagnose this as a patient of benign intracranial hypertension. So important point is that imaging is very useful in this condition, and if you suspect that, ask the MRI radiogram with plain MRI, and you will be. Now we will not discuss this low CSF pressure headache. And many of you must have seen that after lumbar puncture person can have headache, and that responds to either epidural blood patch or by giving caffeine tablet in 3 to 5 days time that clears. But in recent years there are advancement in the low intracranial pressure headache, and detailed discussions and extensive is available. There are many conditions in which this can occur spontaneously, so that is called spontaneous low intracranial hypotension. We will not deal with that because we are short of time. Now, headache associated with the substance use or withdrawal is known to everyone. Say a patient of the chronic alcoholic, in the morning person will have headache because of the withdrawal. And headache associated with the non-sympathetic inflammatory variation, fatty infection, known to everyone, and we will not deal with that. Headache associated with the metabolic disorder, hypoxia, hypocapnia, hyperglycemia, dialysis are well known. Headache or patient when associated with disorder of cranium, neck, we will not discuss with that also. And then cane and rotator, we will not discuss that. Now, history is important. And in any segment of the internal medicine and the medical side, the history is very important. Now, suppose the first or the worst headache is there. The primary headache can occur at any time, but most often they begin during the childhood between 20 and 50 years of age. This is important. I have diagnosed patients of migraine at the age of 60 years. First attack of headache at the age of 60 years. So they were put into the level of probable migraine. There is method of diagnosing it by applying diagnostic criteria, and after imaging, ruling out the other conditions, I labeled the patient as having first attack of probable migraine. He was treated on the line of, she was treated on the line of migraine. She responded very well, and when drug was withdrawn, she had recurrence of the headache, which was very typical of migraine. So it is very unusual to have headache at the age, first headache at the age of 60 years, but I did see such patients, and I expect that I will continue seeing. But those who are not headache specialists, or they see less patients of migraine, at the age of 60, if you are diagnosed migraine, you think twice before doing that. Okay? Then comes the onset of headache after 50 years age is a red flag for the consideration of the secondary headache, such as we have discussed temporalitis or mass lesion. So after the age of 50, if you are coming across a patient of headache who is not having a typical lifetime history of primary headache, think of metastasis, think of tumors, think of temporal arteritis, and HIV-related problems. If the patient routinely has headache, it is important to determine whether the current episode is typical, is this headache like the ones you usually have. This is also important. In a patient of migraine who has got attacks of migraine, lifetime history of migraine, if the new onset, another type of headache is there, you should be alerted. It may be a mass lesion, it may be some different history. Now, regarding symptoms, what symptoms do you have before the headache starts? This is important. Now, last year we discussed a bit about the migraine, and I can repeat that migraine has 3 or 4 phases. Now, earlier it was thought that migraine has 3 phases. Now, another phase has also been added. So, first is prodrome. During the prodromal, the person can have lack of concentration, yawning, and some autonomic signs, and dulling, etc. That is called aura. So that is called prodrome. And then comes aura, and everyone knows it. And acute attack, and then comes the postdrome. So it is important that if you have got a patient who has 1 or 2 attacks of migraine, but is giving typical history of symptoms, which is fitting well into prodrome of migraine, perhaps you are dealing with a patient of migraine. And then you can also take family history and imaging, etc. And then you will be sure, and patient will be labeled as a patient of probable migraine. But the thing is that if you know about the prodrome, you will be corrected. What symptoms do you have during the headache? This is also important. Say in a patient of typical migraine, you will have photophobia, phonophobia, nausea, vomiting, or a combination of these all. And this is important. And in patients of that, you will have written set of history. What symptoms do you have right now? This is also important. Okay. Now, a patient of migraine can have another headache. He can have headache because of some other reason. A doctor may have treated a patient of biologic major disease, a lifetime migraine. This has happened with me. And suddenly he said, "There was a headache." And the patient was a patient of biologic disease for biologic major because of he was treating another patient for biologic major disease. He was treated for biologic major. So it's very important. I have been treating his migraine for years together. His whole family is having migraine, and the man landed with the biologic major disease, and he was sick. No time he was okay. So then we come to next week. Okay, I think we will not be much about this. Now, regarding the severity of the quality of the pain, the transient headache, has got very interesting thing. They are not very severe. They are never very severe. This is important. They are mild to moderate. They are pressing or lightning pain. Now, person can keep on working. His quality of work will also not be affected much. And work hours will not be lost when patient is having tension headache. In cluster attack, it will be severe, stabbing pain, and it will immediately cause the person to work. Migraine headache will be moderate to severe. So moderate to mild, in the mild to moderate attack person will be able to work. In severe person will not be able to work. And it will have versatile to wing or the wing character. Now, at this stage, I may say, it is very important to see that migraine is not just looping headache. This is a misconception. It is not just vascular headache. The theory has now changed, and it is said that the migraine originates in the brain, number 1. Number 2, it is not throbbing and unilateral. It can be the leaking also. Now, we will skip many of these things. Now we come to diagnostic criteria. We discuss a bit about primary attacks, about secondary attacks, and a combination of primary and secondary attacks, and say that be alert that any patient of secondary attack may be associated with a primary attack, or a migraine patient can have other conditions. So this was the thing. Now, what are the diagnostic criteria for first attack? Now, for any type of conditions in medical medicine, your diagnostic criteria, what is the methodology? You frame a condition, you give the definition of the condition, disease, and then you attack symptoms, give the weightage, statistical weightage to that, and then you develop the diagnostic criteria. So same is true for the migraine, cluster headache, and tension headache. So what is the diagnostic criteria for the cluster headache? At least 5 attacks fulfilling criteria B through D. Number 1, severe unilateral orbital. Now, this is very important. Number 1, severe. They are usually severe. Person is disturbed. In fact, many have committed suicide because of cluster headache. Severe. Then strictly unilateral. Carry home message. If you come across a patient of primary headache and you are dealing with the trigeminal autonomic cephalalgia, whose prototype is cluster headache, they will be strictly unilateral. They will not be bilateral. So if you are coming across a patient who has features of migraine but strictly unilateral and has got other features, think of cluster headache. We will see what are the other things. Number 2. Then orbital or supraorbital. This is important. All attacks, all the patients of trigeminal autonomic cephalalgia are around orbit. Attacks will be in the different area, but the main thrust will be around the orbit or into the orbit. This is important. And therefore, glaucoma comes always into differential diagnosis. Now, it may be a temporal pain lasting 15 to 180 minutes. This is important. Just 15 minutes to 180 minutes. So different attacks have different duration of headache. So you will have to learn by heart, and by practice you will know that this is cluster headache. There are other features, but by duration, the shortest headache will be some. The cluster headache patient will have headache lasting 15 to 180 minutes. And then this headache is associated with at least one of the following signs on the pain side. This is important. On the side of the pain, conjunctival injection, prototype of it, lacrimation, nasal congestion, rhinorrhea, forehead and facial sweating, meiosis, ptosis, eyelid edema, and frequency of attack, 1 attack every other day to 8 attacks per day. And out of these attacks, 1 attack will have periodicity. So 1 attack is occurring in the night. Another attack will also occur at the same time on the night, or same time of the day, or 2 attack patterns can emerge. 1 attack may be at midday, another may be in the midnight. So they will be repeated. In between these 2 attacks, there can be irregular pattern of the headaches, but attacks will not be more than 8 attacks to 10 attacks a day. That's okay. So this is important because this will differentiate cluster headache from other headaches. Other trigeminal attacks. Now, what are the diagnostic criteria for that? I think you should not go into detail of it. Very simply, tension type headaches are mild to moderate. Number 1, they are featured as. A very practical point is, if imaging is normal, preferably MRI, and they are featured as 1 or 2 features of migraine like protoconophobic may be there, but not both of them, and not any other feature. Mild nausea may be there. If that is that, I think you can confidently diagnose it for a patient of tension type headache as tension type headache. Then comes diagnostic criteria for the migraine without aura. So at least 5 attacks fulfilling criteria B through D. Number 1, attack lasting 4 to 72 hours. This is very important, and almost everyone is familiar with this. That attacks last 4 to 72 hours. This is important. At least 2 of the following pain characteristics. Number 1, unilateral location. Now this is not very important. This is one of the diagnostic points. All patients will not have unilateral attack. They can have bilateral. It can be on the onset by unilateral, and then it can become bilateral. The onset may be bilateral, and then it can become unilateral. So unilaterally is not very important. It is just one diagnostic point. Then versatile character. This is another pattern. It may not be versatile. It may be just non-profit. Then comes moderate or severe intensity. This is important. Usually mild attacks are not there. A patient who is on treatment may have mild attack of migraine, but most of the patients of the migraine will have moderate to severe headache, interfering the work. Then comes your aggravation by walking, stress or similar physical activity. This is important. So many patients are disturbed by the fact that they cannot do walk, they cannot do much of the walking exercise, they cannot do purchasing, and they just planning is related to headache. And particularly these patients are also susceptible, and you should take history about that. They are susceptible to have trouble intolerance. So many of my patients have this, and I think 40% of the patients of my migraine patients have travel sickness. This is important. But because if you are able to take history of travel sickness, you start treating the patient's travel sickness and he will be comfortable. कि डॉक्टर साहब हेडेक तो ठीक हुआ, साथ ही साथ मैं आपके गांव से भी आपको दिखाने आती हूँ, तो इस बार मुझे फिक्र भी नहीं है, आपने जो गोली दी ना सुबह का नाम, and this is very simple, cheap. The carry-home message is the motion sickness is treated with the sedating antihistamine. Never treat with the non-sedating antihistamine. The motion sickness, which is common and associated with the migraine, is always treated with the sedating antihistamine, diamine hydrinate and dramamine. Okay? So these are the things. During headache, at least one of the following should be there. Nausea and vomiting, we have nausea. And photophobia and phonophobia. So these are things. Then, now, in clinical practice, usually a simplified diagnostic criteria for migraine is used. I have picked this from the Harrison. So what does this say? That you should be able to say that repeated attacks of migraine lasting 4 to 72 hours with a normal physical examination. This is important. No other reasonable cause for the headache, and I always go for imaging. Imaging is negative, you are comfortable. And then comes your at least one of the two of the following features. Unilateral headache, throbbing pain, aggravation by movement, moderate or severe intensity. Nausea or vomiting is now one of the two related. Nausea, vomiting, photophobia and phonophobia. So if you concentrate on these features, most of the patients of migraine may be diagnosed comfortably. Red flags. Now, if a patient of headache is having fever, everyone will be alert. This neck stiffness, you will be alert. If it is rash, I think it is of course. And it is often with think of antibiotics. Now, focal neurological signs like that can be seen in mass lesions, muscle malformation, stroke, collagen vascular disease, and papilloma is there, mass lesion, muscular tract and meningitis. Pyogenic meningitis usually does not lead to papilloma. This is important. So this is important because papilloma has to take some time to develop. And in patient who is pyogenic meningitis, either he will be recovered or he will die before the papilloma. So if papilloma is there, think of chronic meningitis. Headache subsequent to head trauma, subdural hematoma, epidural hematoma, and post-traumatic headache. So these are the red flags. Now regarding investigations. Now I have seen many patients when I have seen many of the patients which would have been diagnosed at the level of physicians. They were missed because routine investigations were not given due importance. Clinical examination was okay. Investigations were there in the hand. Still they were not analyzed properly. So this is important. Don't take any investigation lightly. Headache, don't do that. Give due importance to every investigation, every clinical feature. Clubbing to anemia, yeah, picked up just by seeing clubbing of the patient. To say that ये क्या acidic तो brain abscess होगा. And it turned out brain abscess. The patient was a patient of bronchitis with marked clubbing and all the features, the features of the bronchitis, and it turned out to be in a patient young baby of 1.5-year-old. If you have palate tetralogy and the suspected it should be these problems and all these problems should be because of brain abscess. It turned out brain abscess. So clubbing is important, anemia is important, everything is important. Everything is important. Neuroimaging, because it is available and is very rewarding. I will not discuss much about it. I always, although here the line is written is neuroimaging is not usually voluntary in patient with primary attack. Even when I diagnose patient as having migraine, I always go for imaging. This is reassuring. Reassuring the patient, the doctor, and you comfortably subsequently the patient. Always go for imaging. It is no more than costly. 30 years back it was costly when I started. 35 years back when I started my career as a neurologist, it was costly. Now it is not that costly. So you should not economize on imaging. Go for imaging. So carry home message is all patients on headache should be subjected to imaging. MRI or CT. Now, case report. I saw when I was a 50-year-old man who had diffuse headache and burning in fingertips, which the headache increased on exertion. He was a smoker and smoking 5 to 6 minutes a day. He decompensated each and every night. And on examination, he had dark red fingers. So who will tell me, any resident will tell me what should be the diagnosis? The whole diagnosis was picked up in 2 minutes time. With the 4 lines, who will give me the final diagnosis for this patient? Any resident? No one has asked any question so far. Any resident will comment on this 4 features? See, whole diagnosis was made with these 4 lines. Who will make any comment? Now, this patient is 50-year-old man. And on examination, he was not having on clothes in body, he did not have any feature of primary headache. See, I always go for headache. Migraine to aapko nahi hai, so he was not having it. Now, headache with the burning in fingertips. Can anyone diagnose this? What was this burning? Burning in a patient of dark red fingers. This is erythromelalgia. Don't get divorced from your internal medicine. This is erythromelalgia. Now tell me the diagnosis. Why this patient was having, what was the final diagnosis? It was made on the spot in the office examination. Okay. Now diagnosis. Polycythemia. Erythromelalgia is feature of secondary. Erythromelalgia is burning fingers. This responds well to aspirin and is seen in myeloproliferative disorders. And this patient was smoking just 5 to 6 minutes. Each and every point is important. So what struck to my mind was why this seasoning. See, first of each and every patient were right. Every patient who comes after 2 years, so say if I have got a patient headache and he is my follow-up for the last 2 years, after 2 years I will see my fingers. I again go for the CT scan. So always risk in the patient. So when I came across this patient, when I saw the pulse and when I saw the dark finger, और सब मेरी तो उंगली में चलो से तो ये तो मुझे और विशेष तरह से मैं रुका okay. JAK2 was positive, very simple. So we have discussed all things and I will not go for the many of the investigations, switching rapidly to the X. So trigeminal autonomic cephalalgia. So Dr. Atulabh told me that you touch upon this subject, so I have included in my slides. So they are relatively short-lasting unilateral headaches with the generalized autonomic symptoms. So autonomic features are there also in the migraine. But here, these features are strictly unilateral. Pain is severe and more than once a day. Now, cluster headache. It is a relatively rare, 1 in 1,000, retroorbital. So, around an orbit. I told all the attacks are around orbit. Severe excruciating pain, periodicity is 1 to 2 to 8 attacks per day for 8 to 10 days. So this is cluster. They come in cluster, go in cluster. They will go back, return back, from season to season, year to year, years together, and then they may not recur subsequently for years together. So this is cluster headache. Patient is restless at the time of headache, as compared to migraine, who will like to sit quit. and will not like to be disturbed. The patient will shuffle in the room. He is not comfortable. He will like to bang his head. So this is cluster headache. Now, what are the parasympathetic features? Conjunctival injection, lacrimation, rhinorrhea, and oral fullness. These are the parasympathetic features. Now, sympathetic features are secondary to parasympathetic. What happens that when parasympathetic system is activated centrally, there occurs neurogenic edema around the sympathetic nerve and they got paralyzed temporarily, and that leads to meiosis and psychosis. So they have unilateral photo and phonophobia. This is very interesting. Carry home message is this photophobia and phonophobia is also unilateral. Headache is on the same side, one side, usually side locked, but the photophobia and phonophobia are also unilateral. Photophobia and phonophobia are unilateral. If you elicit it, and this is interesting, once you are elicited, you can say this is not migraine. All of the features may be there, are overlap of cluster headache with the migraine, and their manifestations have both of them. But if it is strictly unilateral, photophobia is unilateral, phonophobia is unilateral, sweating is unilateral, recently flushing is unilateral, lacrimation is unilateral, hearing is there. This is cluster headache. What is the rest of the things? Now, regarding the treatment, 100% oxygen is very interestingly patient respond to it. Then nasal support is somatropin, short-term steroid, and in recent years, the greater occipital nerve block or stimulation has also helped. So remember, if you are not able to manage a patient of a cluster headache in your OPD, refer the patient to neurologist for the greater occipital nerve injection. In recent years, calcitonin gene-related polypeptide monoclonal antibodies have come into picture. They are very useful in acute as well as in the prophylaxis of the cluster headache. Galcanezumab is the biological agent which is useful in acute attack. Now, regarding preventing long-term treatment, Verapam is the drug of choice. The earlier Valpid was given more emphasis. In recent years, it has been found that Verapam is better drug. Gives very good results. Constipation and conducting disturbances are the major side effects. Melatonin has also been found to be useful, and in one of my patients, the melatonin in 3 milligram per day gave very good results. So melatonin is a new drug in our armamentarium. Topiramate is also very useful. I have stopped using lithium because of fear of renal toxicity, but literature says that it is a very good drug. And very honestly, in last 20 years, I have not seen any patient, I have not treated any patient with lithium. One patient was under another neurologist came to me and I continued with lithium, but I have not treated any patient with lithium and it did not lead it. Gabapentin is also very useful, and one of my patients responded very well to about more than 2,400 milligrams of the gabapentin, but they did it well. Now, regarding the vein and femur, this is also very important. Carry home message is, if you come as a patient of cluster attack, more patient will be made as against the migraine where the ratio is 1:3 in favor of 3 women versus 1 male. Here, the ratio will be opposite. It will be more male preponderance and less female. Now, regarding the treatment of the attacks, the neuromodulation, you can do sphingomyelin ganglion stimulation, non-invasive vagus nerve stimulation. They are very useful. And very recently, US FDA has also approved DBS, which, as you might be knowing, is useful in the treatment of the Parkinson's major ganglion disorder, and also in schizophrenia and OCD. Now, DBS has also been approved for the resistant patient of the cluster headache. So, if DBS has been approved, you can understand that cluster headache is not that easy to treat. Occipital nerve stimulation we have already discussed. Now we have discussed the preventive measurement, clinical picture of the trigeminal upper. Now this chart shows the main trigeminal attacks. So at the one end is cluster headache, the second is paroxysmal hemipnea, third is SUNK. And I have not added and in fact many are not considered hemic continue as the true trigeminal autonomous area. So what are the features of these conditions? We have discussed the cluster attack. So regarding the paraximal hemicrania, the male-female ratio is equal, and it has what are the type of the headache? It is throbbing, boring, stabbing, and it is restorative and orbital. So important point is orbital. So how to differentiate this from the cluster headache and the paroxysmal hemicrania? The cluster headache basically are 1 to 8 per day, and they are 1 to 20 per day. Now, some it may be 3 to 200 per day. So what is some is short lasting unilateral neuralgiform headache with the conjunctival injection and tearing. If conjunctival injection and tearing is not there, but autonomic features are there, then this becomes sooner. So without conjunctival tearing, now carry home message is you get the macropatient of some. How to diagnose it? Very short lasting pain, like that of the trigeminal neuralgia, but longer than the trigeminal neuralgia. Trigeminal neuralgia headache is 1 second, maximum 2 seconds, not more than that. Here the headache will be lasting 1 second, 400 seconds. They may be 1 to 20 to 2, they may be 3 to 200 per day. Strictly unilateral, orbital, periorbital, and burning and stabbing in character. There will be conjunctival injection, there will be tearing, and if it is not there, but the pain, character of the pain is lack of sun, they are 3 to 200 in a day, that will become suna. So suna is conjunctival injection, and suna is the attack with the features of recurrent attack, more than 200 attacks per day, very short lasting, with autonomic features, but without tearing and conjunctival injection. Now, duration of attack we have discussed is 15 to 180 minutes in the cluster headache. It is 2 to 30 minutes in paroxysmal hemicrania, and it is 2 to 40 seconds in the sun. Now, what are the marginous features? Are they there? Yes, they are there in the cluster headache. They are also there in the paroxysmal hemicrania, and they are also there in the sun. They are usually not there in the hemicranial continuum. So that differentiates from these three positions. And then comes alcohol treatment. This is important. If someone develops headache and you are thinking that it is strictly unilateral, orbital, and it is recurrent, but aggravated by the cluster headache, aggravated by the alcohol, likely to be cluster headache. It is unlikely to be paroxysmal hemicrania, which comes into the differential diagnosis. Then cutaneous trigger. Cutaneous trigger is not there in cluster headache. This is important. This differentiates it from the trigeminal neuralgia, from paroxysmal hemicrania, from the but the cutaneous trigger is also not there in the paroxysmal hemicrania, but it is there in the sun. So this sun is differentiated from the cluster headache and paroxysmal hemicrania by the cutaneous trigger. So sun share the cutaneous trigger with the trigeminal neuralgia. Here it is very short lasting, it may be 200 attack a day, like sun, but there the conjunctival tearing, conjunctival injection and tearing will not be there. In trigeminal neuralgia it will not be there, autonomic features will not be there, here the autonomic features will be there. So regarding the treatment, now indomethacin effect. The indomethacin gives startling results in paroxysmal hemicrania. In fact, 3 of the primary attacks are diagnosed retrospectively by their response to indomethacin. So one of them is paroxysmal hemicrania, second is hemicrania continua. So the way indomethacin gives excellent results, wonderful results in patients for paroxysmal hemicrania. And so if you diagnose a patient having attacks, but you are confused with the cluster headache, there are many features to differentiate from, but still not able to differentiate, give steroid, give indomethacin. With the low dose, you should get very good results. few patients do not respond to the low dose, and then you have to increase the dose. When you are increasing the dose, respond to increased dose of that, now you should get allergy. All attacks have a habit of having association. Attacks may be secondary to pituitary masses, supracellular masses. So if you are increasing the dose and you increase the dose to the point where it becomes 300 mg per day, perhaps you are dealing with a patient of pituitary adenoma. So carry home message is, if you diagnose a patient of having attack, always go for imaging and look for the supracellular mass. You may perhaps be dealing with the secondary tags. This is important. Now, regarding the abortive treatment, ignocaine is about some role in some, and there is no drug for the abortive treatment for the paroxysmal hematuria. And for the preventive treatment in paroxysmal hematuria, indomethacin is good. Recently, gabapentin and topiramate has also been found to give some results. So this chart shows that in case of pain in the trigeminal facial or the headache, the trigeminal neuralgia has shortest duration. Some has got about 2 minutes. Paroxysmal headache is having one headache attack of around 15 minutes. Clustered headache is it can last from 15 minutes to 3 hours, while the migraine will last 4 to 10 hours. The trigeminal neuralgia frequency will be highest. So a person is having pain in the trigeminal distribution, the frequency will be highest with the trigeminal neuralgia, then will come the sun, and then will come the trigeminal hematuria, and just a headache, the attack will be less than 8. This slide shows that this patient of cluster headache is having right-sided cluster headache with rhinorrhea, ptosis on the right side, and meiosis. This patient was recently picked up by me in the OPD, and this patient was first seen by me in 2022, and the diagnosis was made and was successfully completed in the laboratory. The drug of choice for the sunk is lemodrazine. The second drug is carbamazepine or oxcarbazepine. Gabapentin is also useful, and some results can be topiramate also gives some good results. But the drug of choice is lemodrazine. It was lost in the follow-up because of certain reason. Now you can see that this patient is having attack of some, and at the start to the end, some condition is there. And by the end of it, the left eye is congested. You can differentiate the two eyes. There is congestion of the left eye. And in 2 minutes time, both eyes was again normal. Now see this one. Sound is not there. What this man is telling is, we have seen that he, let us repeat it. So what he is telling is that when touching left side of the face or head, he is having attacks of sun. you can see he has almost all the features of some. You have seen that in seconds time he developed left-sided fixation. So in short, he was lost in the water because he was comfortable. He was taking lemotrazine, reduced the lemotrazine. He said being induced lemotrazine and landed up with the lemotrazine skin rash. So this is all about this one. So thanking you all.
Thank you very much, sir, for such a nice and elaborated presentation. If there are any questions or comments, please, you're most welcome. Otherwise, so whosoever wants to learn Botox, right? So we are just defining this Botox session in the end. So, I mean, as a physiotherapist or rehab persons, one should know Botox injections. I mean, this is used in, I always say this is used in beauty parlors and doctors are hesitant to do that. So that's bad. So stay back. So in the end, Dr. Adnan specifically would talk about Botox and how to inject it, what are the conditions, what are the indications. So that we are deferring since, so now we break off for lunch and soon after the lunch we'll hear from Dr. Nirmal Surya. So that's going to be a key talk. So be here in time, come back first.
सर का इसके जस्ट बाद यार इसमें ये सारा हैंड होता है क्या? ये हैंग नहीं होता? पॉज नहीं होता है।